Well, everyone, welcome to the 2019 GOJO Symposium, Unraveling the Mystery of the Joint Commission Survey. What is the expectation around hand hygiene? My name is Megan DiGiorgio, and I'm the clinical manager at GOJO. Every year, we are grateful and amazed by the number of infection preventionists who join us so early in the morning to share in our passion around hand hygiene. And is anyone from the West Coast? You guys are amazing. It's the middle of the night and you're here with us, so thank you for that. There is coffee in the back of the room if you need it. The reason why we're here today is in 2018, the Joint Commission issued an update stating, quote, any observation by surveyors of individual failure to perform hand hygiene in the process of direct patient care will be cited as a deficiency, end quote. This caused some confusion and uncertainties among IPs and hospital leadership, and many of us in this room have wondered what this means for a survey, and more broadly, what are the Joint Commission's expectations around hand hygiene? Our speaker today is the perfect person to help us make sense of all of this. And you may have noticed that this morning we're kind of bursting at the seams with room capacity. When our presenter gave a webinar for the Joint Commission a few months ago, she actually crashed the system with over 2,000 participants. So we're honored to welcome Sylvia Garcia-Houchins, who is the Director of Infection Prevention and Control at the Joint Commission Enterprise, a position that she's been in since April of 2018. Sylvia has over 30 years of experience in both acute and long-term care settings. And most recently, she served as the Director of Infection Control at the University of Chicago Medicine. Concurrently, she was an intermittent consultant for Joint Commission resources for over 10 years. She has provided infection prevention and control consultation, assessment, and education in a variety of healthcare settings, including hospitals, health clinics, ASCs, dialysis centers, both domestically and internationally. Sylvia started her career as a microbiologist, but she went back to nursing school when she was trying to figure out why healthcare workers were not complying with basic infection control standards, including washing their hands. Before we begin the program, there are a few housekeeping items. First, you will receive a copy of the slides. I know that's always a question that we get every year. You will get a copy of the slides, but only if we have scanned your badge. So please make sure that you were scanned on the way in. You can also get scanned on the way out. You can raise your hand now and someone can scan you, but that is how we know that you attended the program. And at the conclusion of the symposium, within a few business days, you'll get a link to an online survey. You fill out that survey, and in response to that, we will send you your CE certificate as well as a copy of Sylvia's slides. So it's important that you get scanned. Lastly, we have a lot of information to cover, and I anticipate a very robust question and answer session. So please hold your questions until the end, but we will have microphone runners. You must speak into the microphone or we're not going to be able to hear you. So that's important, and we'll try to get to as many questions as possible, but we have a limited amount of time for question and answer. So without further ado, please join me in giving a warm welcome to Sylvia Garcia-Houchins.
Thank you, everybody, and thank you so much for getting up this early. It's really wonderful that we all care so much about hand hygiene that we would get up this early. I was really shocked. So let's go ahead and get started. We don't have our prompt monitor going. So I'm going to go ahead and get started. I have to start with our Joint Commission disclaimer. So I need to tell you these slides are current as of yesterday. So, we're always updating to the last minute, but they are cue points. And as cue points, they cannot stand by themselves. So please, feel free to take notes. If you have questions, please contact me at the Joint Commission. I am available to answer your questions, but we often find that people use Joint Commission slides and they say something different. And they're not sure that they can ask. And so if there's any slide that doesn't make sense to you later on, ask, what did you mean by this slide? I didn't quite catch what that meant. One of the things that I have found, I have been at the Joint Commission since April of last year. And I can tell you for 30 years, I thought, well, why are they doing this to us? And, you know, what's happening? And how come I can't ask questions? Because it's just so easy. It'd be so much easier if somebody would answer my question and we'd be over with this, right? And what I have found is the Joint Commission is more than happy to answer your questions. More than happy to answer your questions. There are a lot of very smart people who work there who will research and try to figure out the best answer for you. So please, use these as cue points, listen, right, and ask questions. This is not your only opportunity, right? In order to meet today's objectives, I will be doing 3 things. I'm going to talk to you about how you develop a compliant hand hygiene policy, right, because that's a lot of times what drives our programs. I'm going to talk about how to develop a program that's compliant with the Joint Commission standards and all the other regulatory body standards. And then I'm going to review the process and talk about what to expect on survey related to hand hygiene. So hopefully, I'm going to answer your questions in the presentation. Right? So the first thing I want to talk about is the Joint Commission standards. Right? The standards provide the framework for ensuring that we provide best practice care. It's a framework. So a lot of people say, well, the Joint Commission says. The Joint Commission actually says very little, and people don't realize that. We just provide that framework within which to work, right? So people want to know, well, where in the standards does it say that? It doesn't usually say that. So please beware when you go to conferences like this one and somebody pulls up a slide and and they took it from the Joint Commission website or a Joint Commission presentation and they say, well, the Joint Commission said, because that's gotten the entire country into a whole lot of problems, right? Because I've been to some conferences where people have pulled up my slide, and then said the exact opposite of what I said. So please, please, please ask the source, right? The other thing I want to talk about is that triangle. So when you look at that triangle, one of my friends says it's like the federal government. We function like the federal government, right? We have the judicial system, the executive system, and then Congress who's making all the rules. Well, at the Joint Commission we have DSSM, which is the Division of Standards and Survey Methods. They're the people who write the standards. Then we have the Standards Interpretation Group. They're the people, like our judicial system, who interpret the standards, right? And then we have the accreditation and certification and operations people, and they're the people who actually survey. When you contact the Standards Interpretation Group, they do not talk to the accreditation group about what your question is. There is no link. You can ask as many questions as you want, and the surveyors are never going to know that you asked the question. Okay, so go back and tell your accreditation managers, there is no link. It's safe to ask questions. It's safe to get clarification. Okay, so I'm going to talk first about developing standards that are standard compliant policies. And how many of you are Joint Commission accredited? All right. How many of you read perspectives? Awesome. So you should already know about this. April 2019 perspectives, we published the hierarchical approach to infection control standards. This is the approach that you should be taking when you are trying to find the right answer to your question. The first thing you should be saying to yourself, is there a rule or regulation? Is there law that says you have to do something? Right? Remember, law is state dependent. There are some federal laws, but primarily the biggest thing that's going to drive your program is what's required by your state. That's all the caveats, right? And then there's the conditions of participation or the conditions for coverage or conditions for skilled nursing facilities if you are being accredited for CMS. Right? Then there's manufacturer's instructions, and you do those 3 in that order. In that order. And if you don't get the answer, then you look at the evidence-based guidelines. And that is where a lot of infection control programs have gotten themselves into a lot of problems because they go first to the evidence-based guideline and they forget about the law. Right? If somebody told you it's a great idea, I have the evidence, it's a great idea that you should drive on the wrong side of the road, you wouldn't do it, right? Right? You would say, oh no, the law says in the US, I gotta drive on the right side of the road, right? You wouldn't just take somebody's evidence. So please think about it that way. We also allow consensus documents when there isn't good guidance in evidence-based guidelines that have been put out there. And then all of that gets used to develop your organizational risk assessment and your policy and procedure. So I'm going to use that framework to talk about hand hygiene, regulations. And I'm going to talk a little bit first about a federal regulation. A lot of times when I want to find the regulation that applies, I do Google. I always used to tell our students in Saudi, Google it, right? Google it. That's the best way. So what do? I do rules and regulations, hand hygiene. Rules and regulations, hand washing. Right? So if you do that, you'll find things like OSHA. OSHA has rules and regulations about hand hygiene. You have to wash your hands when you take off your gloves. And one of the most frequently asked questions we get is the sink. My decontamination room doesn't have its own sink. What do I do? Well, OSHA says you gotta wash your hands when you take off those gloves, right? OSHA also provides letters for guidance. So if you Google OSHA, hand washing, which is what I did, right? You will find a letter that explains what to do if you don't have a sink in the room and the person's taking off their gloves so that you can remain standard compliant. Okay? Now let's talk about your state regulations, right? So this is Illinois, which is where I came from. I came from Illinois, right? Born and raised there. What's the rules there? Well, if you read the Illinois Rules and Regulations, the Administrative Code, you will see for hospital licensing that they have incorporated by reference certain documents, including the CDC guideline for hand hygiene. So in Illinois, you do not have a choice. You must follow the CDC guideline because that is the law if you are a hospital. The other thing that's in there, which a lot of people don't realize, is that even if you are not a deemed organization, even if you're not trying to be accredited, if you are a hospital, you still have to follow the conditions of participation because it isn't being incorporated by reference in the state of Illinois. So very important to look at your rules and regulations. Very important not just to look at the infection control section, but to look at all of the documents that have been incorporated by reference. Right? The next thing is CMS. Right? So in Illinois, we have to follow the CMS conditions of participation regardless of whether we're deemed or not deemed. Right? But if you are seeking accreditation for CMS, then you have to look at those conditions of participation. Where do you find the majority of information for hospitals and ambulatory settings? It's in the infection control worksheets. Right? I have provided you, and you'll get that when you get the links, provided you with the website to go in and find survey and certification letters. Those are the directions that are given to surveyors and accrediting organizations on what they should be surveying you about. They provide clarification. Right? Every infection preventionist should know about these worksheets. Every infection preventionist should have pulled them up already and been using them. So if you're new, this is where you need to go. Right? So what did they say about hand hygiene? Well, they say that soap and water and alcohol-based hand rubs must be readily accessible in appropriate locations. And they do give you some suggestions as to what appropriate locations would be. Right? Like outside of the patient room, inside of the patient room. So they answer those questions that come up every day. They also tell you when you should be performing hand hygiene. Right? Go back to those 5 moments. Now, if you look at the hospital infection control worksheet, they provide further guidance. They talk about hand washing with soap and water. Most people haven't gone back and really read these documents because I can tell you we get survey findings every day about people not washing their hands with soap and water for a patient who has potential C. diff because their policy and procedure says wash your hands with soap and water. If you actually look at the requirement and you look at the literature says during an outbreak or period of hyperendemic, an hyperendemic period, right? And then what about those nails? What about those nails? What does your policy say about nails? What's the requirement around nails? Well, if you actually go to CMS infection control worksheet, it says, do not wear artificial fingernails or extenders when having direct contact with patients at high risk of infection per hospital policy. Per hospital policy. You get to decide your policy. We have infection preventionists, perfect is the enemy of good, and you're going to see that later on, right, who have written their policies so strictly that you can't walk into the hospital if you are a healthcare provider. Even if you don't touch a patient, you can't wear artificial fingernails or nail extenders. That's much harder to enforce, right? And what about surveillance? If you go into the CMS hospital infection control worksheet, does it say you have to do whole house surveillance? No. It says you have to have a QAPI program. You have to have a process for improving your processes at your hospital. You have to have successful corrective action plans, and you have to do it, you have to decide what you're going to do based on your risk assessment to prioritize what you are doing as far as quality indicators. Are you getting the idea that you got a lot more choice here? You got a lot more choice than you think. Do not listen to the person who says, oh no, you have to do this because the Joint Commission says so, or CMS says so. Ask the questions, right? So what about manufacturer's instructions for use? So we get a lot of questions about manufacturer's instructions for use. Do you have to follow them? Yes, you have to follow manufacturer's instructions for use. And people follow the process. They use this hierarchical approach, and they get to the manufacturer's instructions, and all of a sudden they say, oh no, I don't want to do that, right? And they start risk assessing. You cannot risk assess away a law. You cannot risk assess CMS requirements. And you cannot risk assess, in most instances, manufacturer's instructions for use. But there is a way to address conflicts or questions or issues that come up. So I'm going to use as the example the instructions for use for CHG soaps. So how many of you have read the instructions for use for your CHG soap? Okay? Some of you have, and that's great. But if you actually read them, you would be in a panic. Oh my gosh, the instructions say I've got to use 5 mLs, 6 full pumps, to wash my hands. Do you think that's reasonable? Not really. But the testing that is required for these products, right? FDA requires that when these products are being tested, they use a 5 ml volume. So as a result, all the manufacturers of CHG products have to, in their directions for use that in their directions, right? But most of your manufacturers, and probably all of your manufacturers, have done additional efficacy testing. They can provide you with a letter or statement that says they have done efficacy testing at a lower volume. The Joint Commission will accept that information. So if the surveyor says, tell me about the instructions for use, gee, I noticed those people are washing their hands, what does the manufacturer say? They pull them out, CHG, they read, oh, you're supposed to use 5 mLs. Why are you not using 5 mLs? They aren't believing that you're going to use 5 mLs to wash your hands. I mean, that would really be unreasonable. Think about a 5 ml syringe, right? We'd have soap all over. What they are expecting is that you have a process to resolve issues. That's what they're trying to figure out, is do you have a process? When you as the IP say, or someone in your organization says, oh yes, it says that, but we contacted the manufacturer and they did efficacy testing and here's a statement from them or a letter from them or an email from them, we will accept that. Okay? All right. So now I'm going to switch gears and talk about evidence-based guidelines. And evidence-based guidelines is what you use when you don't get your answer from the first 3. That's when you go to your evidence-based guidelines for most things. However, the Joint Commission has been very clear about hand hygiene. We all know hand hygiene is the foundation for infection control. Right? And it does decrease hospital-acquired infections. So that's why we think it's so important, right? And unless required by law, you must pick either CDC or WHO hand hygiene guidelines, one or the other. And you must implement a program that follows 1A, 1B, 1C. 1A, 1B, 1C. I cannot say that often enough. 1A, 1B, 1C. Not 2. 1A, 1B, 1C. Yet we see organizations who have literally taken the CDC guideline and not even considered whether or not 2 should apply, and have written policies that are so stringent that their employees can't do what's in the policy. So the only requirement is 1A, 1B, and 1C. Okay? You have to set goals for improving your compliance with hand hygiene guidelines. Right? You have to set goals. We don't tell you what the goal is, but you have to set a goal. Right? And then you have to improve your compliance with hand hygiene. We want to see your hand hygiene getting better. There is no expectation that it is 100%. And I'll talk about that in a minute. That's the elephant in the room, right? So what are the key differences between the CDC and WHO, the World Health Organization? Well, there's some nuanced differences, right? When do you use soap and water? I think everybody agrees. If the hands are visibly soiled, you need to use soap and water. What do you do if there is no soap and water available? OSHA did a great job. They actually said, in the interim, you can use alcohol-based product with a paper towel, or you can use the towelettes until you can get to a sink to actually do soap and water washing. Right? So they gave you alternatives. Right? The other thing is spores. Spores, right? So what do you do with spores? Did you know the CDC guideline does not even talk about C. diff? If you do Control F, you will not find Clostridium difficile in the hand hygiene guideline. Yet we have written policies that reference CDC and say that we should use soap and water. It's not there. It's not in the CDC guideline. Who says if you have the potential for exposure and it's strongly suspected or proven, including outbreaks of C. diff, then you should wash your hands with soap and water. Preferred to wash your hands with soap and water. It doesn't say you have to. Because there's literature out there that says even if you're using an alcohol-based product, you don't have an increased rate of transmission. Right? And we've put this out there as everybody's got to wash their hands with soap and water. Right? The biggest difference between CDC and WHO is hand hygiene technique and how much time it takes. Right? CDC says at least 15 minutes. Sorry, seconds. Seconds. Oh my God, 15 minutes. It's too early in the morning. Seconds. 15 seconds, sorry. You're all awake? CDC says 15 seconds, right? And if you actually read some of the literature, if you read the MDRO literature, it may be 20 to 30 seconds for multi-drug resistant organisms, right? WHO says 40 to 60 seconds. Wow, that's a lot longer, right? 40 to 60 seconds. And by the way, you have to do it a certain way. Now, if you go overseas, you will see most of the organizations use WHO, and you can tell right away. Person goes up to the sink, takes their pump, and starts this back and forth, and this, right? You can tell when they're following it. In the US, it's a pump, right? I did my hands, I'm good to go. Right. So does it make a difference? Well, if you actually read the literature, the WHO process is probably better, but it's not a requirement. So we aren't going to score you to it. Okay? You choose. So what are the other Joint Commission requirements? The hospital implements its infection prevention and control plan. So whatever you decide in your policy, that is part of your plan. And we will make sure that you are implementing your plan. As part of implementing your plan, you are required to follow standard precautions. And so this is where people say, well, what is standard precautions? Some people confuse it with universal precautions. Remember that terminology from HIV and bloodborne pathogens? Standard precautions, if you look at the accreditation manual right now, points you to the general CDC link. The general CDC link. Starting in July 2019, it will point you to the CDC core infection prevention and control practices for safe healthcare delivery in all settings. CDC went to HICPAC in 2014 and said, please review all of the infection control guidelines and tell us which ones are relevant, tell us what we need to be doing as core practices in all healthcare settings. That's where we will be pointing you to when you think about standard precautions. So what's included under standard precautions? Look at that first one right there. Hand hygiene is part of standard precautions. So you must implement standard precautions, so you must implement hand hygiene. There's a lot of other things in there like PPE. You're going to be hearing a lot about that in the future. It's on the list, right? So what are the Joint Commission requirements? We take those core practices for safe healthcare delivery, and we read them, and we take those and give examples to our surveyors on what it is that they should be looking for. Right? So this is just a quick slide. You can look it up yourself, but please read the core practices for standard precautions. Right? There are other evidence-based guidelines that could apply to hand hygiene. For example, Facilities Guideline Institute. Your state may or may not have adopted by law a version of FGI. Then it turns into regulation. How many sinks do you need to have? Where do they need to be located? But FGI gives guidance on how many sinks for how many patient rooms. Where should the sinks be located? How many sinks do you need for decontam? And by the way, you need a separate hand hygiene sink. That's where it comes from. And by the way, FGI is available, read-only copy to everyone in this room. Google it, FGI, read-only copy, whatever year your state has adopted, and you can have access. You don't have to pay for it. Use your resources, use them wisely and cost-effectively, right? The other places you're going to find other hand hygiene guidelines include AMI. AMI talks about when you should be performing hand hygiene, AORN, and many professional organizations put out guidelines, evidence-based guidelines that address hand hygiene. So you use all of that to develop your policy and your procedure at your facility. You need to use the recommended approach, because if you use the recommended approach, you're going to get to the right answer, and you're going to be able to explain to a surveyor, how did you get to that answer? How did you get to your answer? You have a process. It's an organized process. You're going to have a lot less questions from surveyors when you can say, I did this in my state, the law says I follow X. You can apply this to any infection control standard. But please, please be aware, I follow the listserv, the APIC listserv. I get it every day and I follow it. And initially I started responding and then I stopped. Right? And I've been collecting it and I'm using it to do frequently asked questions, and I'm using it as the foundation for saying, oh my gosh, there's a need for education here. Right? One of the things that I see is, hey, does somebody out there have a policy? Can you share it with me? When you accept that policy, you need to think about what state that person is in. Are they an accredited organization for CMS? What products are they using? You have to take all of that into account. What evidence-based guideline? Did they reference what they used? So please be very careful of just copying policies and procedures, especially if you have organizations in multiple states. So what's the impact of facility policies on survey? Right? So I made this one up. This is ABC hospital policy about inserting peripheral intravenous catheters. So in this policy, it talks about, right, inserting peripheral IVs, you got to have competency, or you got to be under direct supervision of somebody who does. You only can use their safety angiocasts, right? You can't bring in your own. Why did I put this in here? Because we see organizations where they have providers who bring in something that's not approved and it's not a safety product, right? Exam gloves need to be worn for all IV insertions. Well, what's not in that policy is, and no, you can't tear the tip off your glove, okay? We know about that, right? We all know about that. We all know about that. And what's the problem with that? Well, I will tell you, I did an outbreak in a neonatal intensive care unit that was the result of someone wearing nail extenders and tearing the tip off her glove. And 3 neonatal intensive care babies died, and 9 other will never be right. They will forever have adverse events and sequelae from that outbreak because the nurse tore off the glove. Okay, so please, you want to give them real examples of why you don't do that, right? However, in this case, the policy says prior to donning gloves for insertion of peripheral IV catheters, hands should be washed with soap and water for 10 to 15 seconds. Okay, is this compliant? Is this the right policy? Show of hands that yes, you agree with this policy as written. Okay. Now, if I asked you why, could you come up here and tell me why? Okay. Some of you probably could. Some of you say, well, I've read this all the time and that's not what I would do. Okay. Would this be acceptable or not? Well, you got to go back to the CDC guideline for hand hygiene. And what does it say? If hands are not visibly soiled, use an alcohol-based hand rub for hand hygiene, right? In all other clinical situations described in items 1C through J. And E is decontaminate hands before inserting indwelling devices, including peripheral vascular catheters. So you should be using alcohol-based hand rub. The only alternative they give you is this antimicrobial soap. Right? Now, how many of us have antimicrobial soap everywhere that they could put a peripheral IV in? No, right? So do you write your policy that way? No, you don't write your policy that way, right? This would not be an acceptable policy because it doesn't meet the CDC guidelines, and that's required, right? So go back to that, what's the regulation, what's the COP, what's the IFU, and then what does the evidence-based guidelines say, right? So let's revise that policy. So what if we say instead, if hands are not visibly soiled, use an alcohol-based hand rub is preferred? Are we now compliant? Yes, because we're telling them use an alcohol-based hand rub, right? That's what we're saying is what we want them to do. So think about how you write your policy. Here's another one, care of patients with known or suspected C. difficile infection, right? Use gloves. After gloves are removed, hands should be washed with soap and water or disinfected with an alcohol-based hand rub unless visibly soiled. During outbreaks, wash hands with soap and water after removing gloves. And by the way, when there's an outbreak, signs will be placed on the alcohol-based hand rub pumps alerting staff. Is this a good policy? Okay, I heard a no. Yes, I heard some yeses. Raise your hand if you would agree with this policy. Not very many of you would agree with this policy. Would this be acceptable? Let's go back to the guideline and let's go back to the evidence. So the CDC guideline says if hands are not visibly soiled, use alcohol-based hand rub routinely. And by the way, they don't talk about C. diff, just as I said before. What's the most up-to-date reference? It's the Shea Compendium, Strategies to Prevent C. diff. And what does it say? It says, although alcohol-based hand hygiene products are ineffective at removing or disinfecting spores in experiments, no clinical study has demonstrated an increase of C. diff with the use of these products or a decrease in C. diff with soap and water. There's your evidence. We're practicing evidence-based infection prevention and control, aren't we? Aren't we? Isn't that what we're supposed to be doing? Yet how many people have really read this and implemented a policy that is not going to take you into regulatory turmoil? This is another perfect is the enemy of good. They just need to wash their hands and perform hand hygiene unless you are having an outbreak. So is this compliant? The answer is yes. That is a compliant policy. And I cannot tell you how many times a surveyor has to score it because they see the isolation sign that says, wash with soap and water only. And the practitioner comes out and hits the alcohol-based hand rub pump. And they say, what's your policy? And the policy says, you gotta wash with soap and water. Then I gotta score this. See the problem? If you look at the evidence, using alcohol-based hand rubs does not increase the risk. All right? So how about developing a standard compliant hand hygiene program? Let's talk a little bit about that, right? Organizations must perform hand hygiene surveillance in all patient care locations. Is that a truth or a myth? How many of you would say it's the truth? Okay, you have some people raising their hands that it's the truth. It is a myth. Don't believe what people tell you. The Joint Commission, CMS, nobody requires that you do hand hygiene surveillance in every single location in your facility. It is not required. There is no law. There is no condition of participation. There are no, well, manufacturing instructions wouldn't count. Even the evidence-based guidelines don't say you have to do whole house surveillance for hand hygiene. You got to perform a risk assessment, and based on your risk assessment, develop your goals for improving hand hygiene. Now, does that mean that you can ignore the outpatient clinics? No. Right? It doesn't mean it. It means during your risk assessment, you assess the risk related to hand hygiene. You still have to include them in your risk assessment because you have to include all services, all treatments, all procedures that you do in that risk assessment. And all geographic locations, remember that? You got to include that in your risk assessment, okay? But your surveillance activities are based on your resources, your goals, your risk assessment. I like to say this one. You want to apply a proactive cycle to developing your hand hygiene program, right? You have to identify your organizational components. What's part of your facility, right? Then you need to evaluate the risk related to hand hygiene in those areas of your facility. Once you get that, then you have to prioritize your risk. We cannot do everything and be good at it, right? We want to prioritize what we are doing based on risk. If you had a leaky roof, if you had a toilet that was leaking, right? And you had a drip, and you had your refrigerator that had a drip, what would you do? Which would you fix first, right? All three are important. How much is it going to cost you to fix the roof? Right? How much is it going to cost you if you don't fix the drips? What's the easiest one to fix? Probably just turn off the water to the toilet, right? They all have different amount of risk. They all could damage your home, but if you can't do all of them all at once, you're going to learn to figure out what risk factor I look at. The same thing is true for hand hygiene. What's your biggest risk? Sometimes it's what's your biggest risk and where could you get the most bang for your buck? Right? What can I fix? And then move on. Right? What can I get people behind? So based on that, based on your risk assessment, you're going to determine your goals. And once you determine your goals, then you have to figure out how you're going to develop your plan and implement it. Right? And then after you do that, you got to make sure that you evaluate. And that's another part that people miss a lot on survey. They're collecting data, they're collecting data, they're collecting data, but they're never doing any improvement. Very important part to do. And the other part that's important is whose responsibility and what resources do you have? All right, so I'm going to talk a little bit more about that. Remember, risk assessment is the foundation for an effective hand hygiene program. It's the foundation. Based on your risk, you're going to develop your plan. You still have to follow all the laws, but you're going to develop your plan. Right? Now, so what are the risks at your facility? Right? Has there been a cluster or an outbreak at your facility? If you're having a C. diff outbreak and you linked it to hand hygiene or lack of hand hygiene, well, gee, it's time to do something about that risk, right? If people at your organization are complaining, this hand hygiene product is drying out my hands and therefore they're not performing hand hygiene, maybe that's your focus, right? To get them to improve their hand hygiene. If they're low in a high-risk area like your NICU or your ICU, right? Your neonatal intensive care unit, your ICU has a low hand hygiene rate. Well, probably the risk of, because there's so much hands-on, is probably higher there. But you decide. You decide what your risks are, what your big risks are, right? Based on your prioritized risk, you develop your facility goals. You must have a hand hygiene goal to be compliant with Joint Commission standards. It's a requirement, and it has to be a documented goal. So you have to have a documented goal about hand hygiene. But based on your prioritized risk, you develop your facility's goal. And one of the ones that you will notice is not on here. Your goal should not be to comply with Joint Commission standards. Because that's not a good goal. That's doing something for the wrong reason. Right? You really need to think about why are you doing this? Why are you doing this? The Joint Commission does not decide why you are doing this. You decide why you're doing this. And I hope it's for the right reasons. Right? Not just because Joint Commission says so, which is what we hear all the time. Okay? As part of developing your plan, right, to implement and monitor your goals, there are some surveillance methods that you can choose. You can choose to measure a product, right? How much product did we use? And if you're resource poor and there's you and you've got 250 beds and you're the sole IP and there just is no more time and no help is coming from above, then, you know, you got to choose what works for you. I'm going to go through each one of these and talk a little bit about the advantages and disadvantages, but you will have these slides, right? So you can measure the product, you can conduct surveys, you can do electronic monitoring, or you can do direct observation, which currently is the gold standard, right? So what about measuring product? Well, what happens when somebody changes the pump on you when you weren't around? Or the product expires? And yes, they have expiration dates, right? Or the product expires. Can you really get valid data on use? Or what if somebody's carrying their own in their pocket and using that one instead, right? So it's really hard to do that. I tried this in my outpatient clinic. I tried this for several years, trying to figure out how to measure it, and it really didn't work very well. We walked around with markers and marked on the container, open the container, mark it, are they really using it? We found some pumps that they weren't using, but we really couldn't get an accurate measurement on what was being used, right? How about conducting surveys? Great idea, great idea. How do your employees feel about hand hygiene? Right? What's their knowledge about hand hygiene? Do they know when they're supposed to do it? It's a great rounding tool to ask questions, and you can use the as a survey, and you can collect that information to identify gaps, right? The disadvantage is sometimes you may not have the best answers because they may tell you what you want to hear rather than what they're really doing. So it's really important. If you're depending on your employees to tell you how often they wash their hands, they're probably overestimating. So I used to do this with our new employees, our nursing staff. I would once a month go meet with the new nursing employees. And one of my topics was hand hygiene. And I'd say, how many of you wash your hands 100% of the time? And you'd have 2 or 3 who do it. And I'd be like, be honest, there's no penalties here. We're all friends, right? We're not going to go report you to your manager. And I'd have 2 or 3 people who'd raise their hand and say, I do it religiously 100% of the time. Do you believe them? What do you think your hand hygiene rate is? Right? This is our bread and butter. We still probably overestimate our own hand hygiene, right? Because there's bias, right? So we got to be careful about that. Okay, let's talk about electronic compliance monitoring. Once you install it, it's collecting data, which is great, right? But you have to validate that the information you're getting is really correct and accurate. Otherwise, people are going to not believe it, right? And it takes a while. It definitely takes a while. Having implemented an electronic hand hygiene system, we used to say it's the Kubler-Ross, right? When you start seeing electronic data that says you're at 17 to 27% compliance with hand hygiene, and all of your observation data says, no, you're in the 90s, you do this, oh my God, what am I going to give leapfrog, right? What are our administrators going to say? Oh my gosh, we've made a mistake, right? The important part is you're getting data, and you're getting data not just when you're there collecting the data, but you're getting data 24/7. That's really the advantage and the amount of data, right? The biggest issue, though, is acceptance by the healthcare workers who don't want to believe it when you first get it, all right? So what about direct observations? It's the gold standard, right? The current Center for Transforming Healthcare talks a lot about direct observation as being the gold standard. The biggest issue for the IP is it's time-consuming, and there's a lot of bias there. If you stand there, how high will your hand hygiene rate go? They all know you, right? If you're the observer, they all know you, okay? And we actually did when we installed our electronic system at my old job, we actually did a trial to see how high we could get it. If Sharon O'Keefe, our president and CEO, went to the unit, what do you think the hand hygiene rate was? 100%, right? When I went, I could only get it to 67%. And as soon as I left, I would say within 30 to 40 minutes of my leaving, it went back to whatever their baseline was. Right? So what does that tell you? There's observational bias depending on who it is. And believe me, I hired medical students to come in at night, people who the nurses would never suspect as being hand hygiene observers. I had a whole cadre. They came in weekends and nights. If you're out drinking and it's 1 a.m. and you feel like doing some hand hygiene observations, stop into the hospital and say hello. Right? At $15 an hour, how many times do you think they stopped? Pretty often. I can pay for my night out because I get 15 bucks an hour, right? But was the data good? We actually did that. We compared our electronic system to what we were getting from observers, who people didn't know they were observers, right? We sent people out, we sent pharmacy students out and said, tell them you're monitoring medication administration and watch their hand hygiene while you're doing it. It was about 1/3 of what we were seeing. Okay? So really not that great, all right? What's the effort you need to collect significant data? Well, North Carolina, University of North Carolina did a great study. This is a terrific study. They did longitudinal analysis 2013 through 2015, 853 beds. They had over 4,000 unique observers. How many of you have 4,000 unique observers? Okay? I can tell you I couldn't do it, right? They made 140,000 observations over a 17-month period. That's a lot of hand hygiene, right? That's a lot of it. And that's that Sentinel study that says hand hygiene works to decrease HAIs. So they did a phenomenal job. And they finally, somebody said, you really do need to wash your hands because you will reduce your HAI rate. But how much effort did they have to put into that study to reach that conclusion? So, at my old facility, this is data from my old facility, right? In 30 days of electronic monitoring, in a 34-bed unit, they got 129,000 observations, okay? We got 129,000 observations, right, electronically, coming to our cell phones every day, because that's what it did, it came to the cell phone, right? And if you wanted to get close to that number using direct observation, it would take you 4.3 FTEs. It would take you over 9,000 hours. How many of us have the resources to do that? Right? We don't. So I ask you, is the juice worth the squeeze? So I had an old boss who used to say, is the juice worth the squeeze? Is your effort worth what you are getting out of it? So if you do direct observation, in order for me to justify an electronic system, in order for me to justify it, what I did was I did a calculation. We used to get about 10,000 hand hygiene observations a year. It's a lot of work to get 10,000 observations, right? But we did about 10,000 observations. I wrote down, I did a calculation. Okay, if the nurse goes into the room at least once an hour, hourly rounding, so 24 times in a 24-hour period. And I have an NSA, nursing service assistant, who's got to go in at least hourly. Okay, so now I'm up to 48 opportunities. All right? And then I get physicians rounding. And they usually go in packs, so there's usually 5 to 6 of them, so maybe they go in 3 times a day. And I started doing the calculation. I calculated that we were doing less than 0.0001% of the possible hand hygiene opportunities. Can I make a change based on that percentage? No matter what I do, it's not going to be significant, right? So this is a summation of what happens. You get less than 1 to 2% of all hand hygiene opportunities if you are doing direct observation, right? So what are the concerns? So last year, I was the new Director of Infection Control at the Joint Commission. I came to APIC, and in a room just like this, someone got up and said, oh no, you can't use electronic systems because they don't monitor the 5 moments. Remember what I said about surveillance? There is no requirement that you monitor 5 moments, that you monitor every hand hygiene opportunity, that you do surveillance in every single location in your facility. Yet people are stuck thinking that they cannot do a good surveillance program or they cannot do a good hand hygiene program if they don't include 5 moments. What I will tell you is pick something, start monitoring, and improve. Perfect is the enemy of good. There is no perfect system out there. I will be honest, there is nothing that is perfect about this, right? But if you even monitor in and out, Boyce did a great review. And he said if you monitor 1, 4, and 5, which is really that entry and exit, you are going to get 81% of the opportunities. So most programs today that we go to monitor in and out. Whether they're doing it by direct observation or they're doing it electronically. They're monitoring in and out because you can't stand in the room with the patient all the time because then the person knows you're the observer, right? And you're going to get skewed data, right? So exiting and entering does provide you with a good estimate, and it's a reliable estimate, and it's what most people are doing, whether they're doing direct or electronic, all right? Please remember the Joint Commission does not require monitoring of all 5 moments. We do not require it. And I stood up last year and said that, right? So please. What we do expect is a proactive cycle to improve hand hygiene. We need you to collect real data that makes a real difference for your patient, and move it along. This should not be paper whipping. I can tell you honestly and truly, and you all know it, nobody in this country is at 100%. Nobody, because we're not perfect. We are not perfect. People are not perfect. And yet we go to organizations all the time who say 100%, 100%, 100%. We read papers. Start reading those papers because they'll say 30 observations were done on a nursing unit. Can you be at 100% if you only did 30 observations? Please look at your data. Use real data to make decisions. Okay? What to expect on survey. So, as most of you know, we use what's called the tracer methodology. Depending on where their surveyor goes is what may catch their eye and cause them to pull a thread. What is it that we need to look at, right? It's not going to be the same for every organization. So when people say, well, they came to my facility and somebody didn't wash their hands and they didn't score it, they may not have seen it, right? Or they may have seen something even more troubling and started pulling that thread. Every survey is different. Every survey is different. I cannot emphasize that enough, right? And now the elephant in the room. What about citing one failure? This is the one that everybody goes, oh my gosh, if they see one person not wash their hands, they're going to cite it. If you have one person not wash their hands, do you remind them? I hope the answer is yes. When we see one person not washing their hands and we cite it, we are reminding you about hand hygiene. It is our job because hand hygiene protects your employees. Is it a bad thing to remind you? No. No, we're calling attention to it. And the thing that comes out of citations is resources. Resources. When the Joint Commission cites something, when CMS scores something, what happens? The organization says, oh, we got to fix this. We need resources for them. So citing one case of hand hygiene is going to make a difference for your organization because it is going to focus efforts in that direction. It's going to focus resources in that direction. It's the reminder. It is the reminder, just like you would remind an employee, oh, excuse me, you didn't wash your hands when you came out of that room. It is the reminder, okay? It is not going to put you in an immediate threat situation or immediate jeopardy because one person didn't wash their hands, but it is going to get you the resources you need to focus on hand hygiene, okay? I want to go over some scoring examples, and I'm going to run out of time, but I want to make sure that you know that you are going to get these slides. So I'm going to go through them very quickly, right? So if an organization does not have a written goal for improving hand hygiene, it's going to get scored, and it's going to get scored as a national patient safety goal, or it's going to be scored as a failure to determine a goal. right? Because this is the low-hanging fruit. Make sure you have a goal. Make sure it's based on your risk assessment, okay? Another one, right? You don't choose a facility, you don't choose a guideline, an evidence-based guideline. If you're undergoing a Joint Commission survey, you gotta pick CDC or you gotta pick WHO, unless your state regulation says which one is gonna be picked for you. So be able to articulate to a surveyor which one you picked. Put it in your policy, that's the easiest thing to do, based on CDC, blah, 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 in your policy, or use it as a reference, right? Low-hanging fruit, okay? Not following manufacturer's instructions. You know what products you use at your facility. If you cannot possibly follow those instructions, what do? You contact the manufacturer to see if they can clarify it in writing, technical services. You contact them and say, you know, this says 5 mLs. Do I really need to use 5 mLs? They may send you a letter or a statement. Nail extenders. Please, please, please. This is one where unless you are willing to enforce it in every single location of your facility, then do not write your policy that way. Look at the risk. Does it matter if the secretary in the president's office has nail extenders? I mean, truly, does it pose a risk? You decide. If you decide it does, then write your policy that way. If you decide it doesn't, then write your policy that way. At minimum, make sure that if your staff is having direct contact with patients, that they are not wearing nail extenders, because there is a real risk. Okay? C. Diff. We talked about C. Diff. I talked about it twice now. Please write a policy that you can comply with, that makes sense, and that is based on evidence-based guidelines, that really is based on the science. Because when we use our efforts to do something that there is no evidence about, we waste important resources that we could be using elsewhere to improve the care of our patients. Right? Sink for use, the same sink we use for washing instruments and hand washing. We all can't build a beautiful new decontam room with all the sinks we need, but we need to be sure that we are space compliant and that we are compliant with regulations, right? And so we will score you to your state requirements for your building code. If you built a building in 1985, and that is still your building, and it did not have a separate hand washing sink, then you need to figure out how to be compliant. Right? That's where you start doing that. Okay, they can't wash their hands because I don't have 2 sinks and I don't have the plumbing and we aren't going to renovate it. What does your state say as far as building code? Because that's what we're going to score to, is your building code at the time that building was built or the time you renovated it. So you want to have that information in advance. Right? During a tracer in the pediatric clinic, the manager walks out with somebody and they don't wash their hands, and the manager doesn't remind them to wash their hands. So the surveyor starts asking the staff, hey, does anyone ever talk to you about hand hygiene? Do they ever give you feedback about hand hygiene? And the answer is, no, they don't. Well, guess what? It would get scored. It could be scored under National Patient Safety Goal, but you might want to tell your leaders it could be scored under leadership, because they are required to implement the plan. Okay? The importance of reminding cannot be overspoken about, right? In order to build a high reliability organization, you need to make sure that you are providing feedback to your staff, that your staff is providing feedback to each other, and that you don't get offended and say, oh my gosh, this happens. The Joint Commission was picking on me because they saw one person not wash their hands and they gave me an RFI. We're reminding the organization of the importance of performing hand hygiene to keep your patients safe. Right? And we're reminding leaders of their responsibility. Okay? Remember, it's not about a number. It's about keeping everyone safe. Hand hygiene keeps not just your patients safe, but your staff safe from taking things home, from being sick. It protects your valuable asset, which is your employee, because the last thing you want is a norovirus outbreak in one of your ICUs, and now you don't have any staff to take care of your patients, all right? Please remember, the Joint Commission's goal is to lead the way to zero. That is our mission. That is our mission. That's our goal for this year and for the coming years. Right? We're leading the way to zeros. We are trying to push the envelope on making sure that people focus on the right thing, 0 infections. We know hand hygiene makes a difference. We know it keeps your patients and your staff safe. We ask you all to make a personal commitment, right? What are you committed to? Are you committed to meeting Joint Commission, or are you committed to making your patients safe? So make the commitment to keeping your patients safe. We want you to establish a culture of safety and collaboration. It shouldn't be punitive. Whatever happens, it should not be punitive, right? And make sure that you deploy highly effective process improvement models. What works and what doesn't is not the same for every organization. If someone could have cracked this nut already, I'm sure they would be a billionaire because they figured it out. But we all have to implement processes that work at our facility and change that culture. Now, you need the answer? Do you have a question? Right? You're looking for what is the rule? What does the Joint Commission say? Please don't go on the listserv and say, what does Joint Commission say about hand hygiene? It's much easier, and you're probably more likely to get a more reliable answer if you ask the Joint Commission. So you can send your emails into the Standards Interpretation Group. If you look, go to the Frequently Asked Question page. So I never can remember links, but the link is down there. Even for myself internally, I'll Google Frequently Asked Questions Joint Commission. My website pops up, and I'm like, oh, that's the one I wanted. That way I don't have to keep it in memory, right? But there's a place where it says, number 1, sign up, okay? Sign up. What are you signing up for? Any frequently asked question update. We are in the process of doing lots of frequently asked questions. They are in the pipeline. They will be coming out. They will talk about manufacturer's instructions for use. What is immediate use steam sterilization? What's happening with hand hygiene and what's the requirement? They are all in the process of being written. So we are updating a lot of our FAQs. So sign up so you get them automatically. And the other thing is, if you have questions, contact us. Contact us. You can click that button. They will ask you for your HCO, your organization number. Please put it in there. It does not go to the surveyors. It is just to let us know about your organization, right? Are you a 500-bed hospital? Are you located in Pennsylvania, or are you in New York? Right? It tells us more information to answer your question. What I generally tell people is, if you're feeling uncomfortable about your question, put in a general question, and instead of clicking the button that says email me, click the button that you would like a phone call. Because there is no record of what you talked about on a phone call. Right? So if you really, really feel uncomfortable, make it a phone call. Right? And then if you're happy with the answer, then you can say, would you mind sending me an email? Because then you still get your answer, and you don't have to worry about your accreditation manager getting upset at you, okay? And that's it. Thank you very much.